Well, good morning, everybody. Welcome to Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the end of the talk. If you're attending virtually, you may enter your question into the Q&A section and we'll read that aloud. Also, a link to the evaluation will be shared in the chat toward the end of the program. And for everybody who is here in person, if you grab that little handout with the QR code, that is your access to your survey. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission to do that. And now it is my pleasure to introduce our speaker for this morning, Dr. Deepak Vivekanandan, originally from Chennai, India, earned his medical degree from Sri Ramachandra Medical College and Research Institute. He began his surgical training as a PGY1 resident at the University of Texas Health Science Center at San Antonio, continued as a PGY2 at NYU Langone Health, and completed a burn surgery fellowship at Jacobi Medical Center before advancing to PGY3 at Northeast Georgia Health System. He has a strong interest in cardiothoracic surgery, particularly robotic cardiac and thoracic surgeries, thoracic oncology, and enhanced recovery strategies. Please join me in welcoming Dr. Vivekanandan.
Thank you for the good introduction. So today my topic is going to be on mechanical circulatory support devices and how it impacts our surgical decision making. And as a general surgeon, what we need to know about these devices and how it impacts our surgical decisions when we do surgery. I have no disclosure. I'm happy to have any kind of collaboration if anyone else is listening to this presentation. But at this time, no disclosures. So learning objectives are, we're going to review the spectrum of mechanical circulatory support devices, the different devices we have on the market right now, which is being used on a day-to-day basis, and how each device, like what's the indications for each devices. We're not going to go specifics into when we would put devices in, because this is not aimed at like cardiology or influencing like what devices go in at what point. It's more for us to understand if the patient is on a particular device, to see what amount of heart failure they have or what kind of heart failure they have. It's just like reverse engineering, I would say. And also understanding the key anatomical and hemodynamic considerations when the device is already in and functioning, and identify the preoperative challenges, which in most cases is anticoagulation, bleeding risk, and also the device dependence, like how much device is supporting their cardiac output. We are also going to outline preoperative optimization, intraoperative strategies to be safe in these scenarios. And also we'll discuss about 3 real case scenarios on how we would approach these cases and try to see them from a general surgeon perspective. So when I was thinking about like topics to present for the grand rounds, we were given different options, and one of the biggest things I saw was like us as general surgeons, like our residents, we have very limited understanding of the different devices which have come to market over the last few years. And most of these patients now are in a point where they are stable enough to get surgical procedures, or in a very critical state where they definitely need a surgical procedure to continue their life and have like a meaningful recovery if they come out of that circulatory support devices. And MCS devices are now being used as a bridge for transplant and recovery, and also as a destination therapy, especially with VADs, which are being put in our hospital. And also surgeons need to anticipate like device-specific risks when dealing with these patients. And at least to my knowledge, we have had like at least 4 or 5 patients over the last few years who have had these mechanical circulatory support devices, and we as general surgeons are being called to manage one part of it. And just putting a perspective, the most common procedure someone gets with the mechanical circulatory support devices, like we always guess, is a tracheostomy and probably a PEG tube placement, because these patients are on the ventilator for a prolonged period of time. They're extremely sick. But the other things which are common to some extent are emergency exploratory laparotomy, if they have like perf viscus or something like that. So that's why I thought this would be a good topic to just give an overview of the complete understanding of the different devices we have. So just to get into classification of devices, there are different ways they classify these devices, but the most common, I would say, are by the anatomical support like locations. But to start with, go by duration and purpose. If it's a short term, there could be like IABP, just like intra-arterial balloon pump. Then we have VA and VV ECMOs, and we have the Impella devices. The long term, the only device which we have right now are the LVAD or the tandem heart, which is like a long term, and many patients can have it for a long course, and it's not like a bridge therapy. You can have them, and patients can have a near normal life with an LVAD. Going to anatomical support, there are like left-sided supports like the IABP, Impella 2.5, Impella 5.5 on the LVAD. And the right-sided support is the Impella RP and Protect Duo. And if you need a biventricular support, it's ECMO, or a combination of the left and right, where they have a left-sided Impella and a right-sided Impella, which is uncommon, but still there's an option. By flow type, again, pulsatile flow is IABP, and continuous flow is all the other devices like Impella, LVAD, and ECMO. Some of the older versions of the LVAD are also pulsatile flow devices, but since most of them have phased out and most of the new devices are continuous flow, we'll just stick to LVAD being a continuous flow device. Let's start with some of the devices which we commonly see. First one is the intra-aortic balloon pump. So most of the patients who are at high risk for PCI or have a PCI and have a very low cardiac output after PCI do have a balloon pump at this point. Like, it's one of the devices which is easily placed by interventional cardiology, and these patients have a good improvement in cardiac output. Even though it's not significant, they are symptomatically better. There are many studies which debate if IABP has good outcomes in terms of longevity and patient survival, but most of them say with IABP, patients have at least symptomatic improvement, even though they don't have any survival advantages, which is still being debated on. So the IABP, to put things very simple, it's like a counterpulsation device to improve coronary perfusion. So one of the most common things which initially when I heard about it and was difficult to get my head around that, it inflates during diastole and deflates during systole. So what happens is, this is a picture which shows us what's going on here. With the inflation during diastole, what we are trying to achieve is improve coronary perfusion, because the coronaries get perfused during the diastolic flow and not during the systolic flow. And during the systole, it deflates, so it reduces the afterload, so there is less force which the heart needs to work against. And if you look at the pressure volume loops, they significantly affect like how much oxygen the patient needs, and the IABP helps to reduce the oxygen requirement by reducing the afterload against which the heart needs to pump. And indications, like I said, it's mostly for cardiogenic shock, and it helps also as a bridge to recovery or transplant. And this, like we said, is a temporary support device and not a permanent support device. There are some contraindications. Not every patient can have an intra-aortic balloon pump. The first one is a severe aortic regurgitation. Just because if you don't have a competent aortic valve, your counterpulsation, when the balloon inflates during diastole, your aortic valve, the flow from the aorta goes back into the ventricle and loads the left ventricle and doesn't function the way it needs to support. So severe aortic regurgitation is a known contraindication to intra-aortic balloon pump. Aortic dissection, again, this is a constant pressure on the aorta. It inflates and deflates with every heartbeat. So any aortic dissection causes like increased shear force, and it just complicates the situation, would be a strong contraindication. Severe peripheral vascular disease, so if you can't have good access and you're trying to put a strong, big balloon through a sheet, and you tend to dislodge the calcifications, and this calcifications is going to make, is going to shower clots everywhere, and they're going to have like peripheral artery disease, and once we have that. Going back into just looking at when the balloon inflates and deflates with the EKG, this sometimes comes up in absites, so it's good for us to understand. If you see, this is the T wave, like that's when the balloon inflates, and after that you see this is the normal pressure, like our aortic pressure. So after the balloon inflates, the pressure goes up, and this helps us to understand if the balloon is in synchrony, so that it happens after your systole, and the balloon deflates in the beginning of R waves. So the balloon gets deflated there, and the pressure comes back to normal and goes down. So just to give an overview of the different cannulas we use, just to give us a size perspective, how big your femorals are, the sheet size is usually between a 7.5 and an 8 French sheet, and mostly inserted by the femoral artery, because most of the time that's where we get access for these devices. And the location of the tip is another important thing. It needs to be like 2 centimeters distal to the left subclavian. So placing it more proximal covers your left subclavian, and placing it more distal covers your celiac and your SMA, and causes complications from that standpoint. Surgical implications, when these patients have an intra-aortic balloon pump and we are called for performing any kind of abdominal procedures or any surgery for that matter, you need to understand the femoral cannulation site, which side it is. It's always safer to have the other side also exposed, so if by any chance we lose the intra-aortic balloon pump during surgery, we have another cannulation site through which we can establish ECMO through. Risk of limb ischemia, anytime we put a sheet in, there is always a risk of limb ischemia. So these patients need to be monitored for peripheral pulses all the time in the ICU. Neurovascular checks is an important part of having intra-aortic balloon pump. So some of the complications, vascular complications we just talked about. Balloon rupture. It's extremely uncommon, but again, balloon rupture can always happen, and there's a chance of gas embolism. So that's something we need to keep in mind. So the patient loses the augmentation, which we saw during diastole, and that shows that the balloon is not functioning, and that gives us an idea that the patients had probably a ruptured balloon to start with. Malposition. So one of the common complications is malpositioning, because imagine you're having your heart which is having continuous cardiac output, and now you have a balloon which is inflated during diastole, through which the blood flows. So the balloon is constantly being bombarded by this flow of blood, and it tends to move. We have multiple sites through which we secure the balloon so it doesn't migrate. But if the balloon migrates and it's getting inflated and deflated, and if they're around the celiac, SMA, or the renals, the patient might end up having intestinal ischemia or necrosis, and also renal failure. So other important thing is, if you're getting called for those situations, is to make sure the balloon is in good position. It can be done using a simple X-ray to figure out where the balloon is, and that's a good place to start. Infection at insertion site, thrombocytopenia, and stroke. Anytime you have anything in your arteries, you have a stroke risk. So I also want to talk very quickly about anticoagulation for these patients. So there are different levels of IABP. 1:1 is when the balloon inflates and deflates with every heartbeat, and you can go from 1:1 to 1:3, 1:4, where it happens only every fourth cycle. So if the patient is on 1:1, technically they don't need any kind of prolonged anticoagulation, because the pulsation from the device, like inflation and deflation, prevents them from developing clots. And if we need to take them for surgery, we can safely take them off anticoagulation and make sure that they can get it done. So if they're on 1:2, 1:3, 1:4, that's when we start thinking about the need for anticoagulation, because there's a higher chance of showering clots down. And so if they need surgery, the easiest thing to do is push them up to 1:1, so they have good augmentation, and take them for surgery safely without anticoagulation, without the risk of clot formation. The next device are ECMO, extracorporeal membrane oxygenation. Many patients are on ECMO. So there are different kinds of ECMO. There is VA ECMO, where as the name suggests, it's veno-arterial. So we take blood from the vein. The bottom picture is an example of a VA ECMO. So femoral vein is the most common access site. We place a cannula, pull the blood out from the veins, goes into a pump, then subsequently goes into an oxygenator, then gets put back into the arterial system, which is usually a femoral artery site. So VA ECMO is primarily used for patients who have cardiac and respiratory failure, or just isolated cardiac failure where they can't have enough cardiac output. VV ECMO, on the other hand, is where it's just primarily used for oxygenation and not augmenting flow. So it's ideally taken from a vein, and the oxygenated blood is again inserted into a vein. So the most common would be a femoral and a jugular access site. The top picture, again, is an example of a VA ECMO. So you usually get it from the femoral vein, goes into a pump, and then goes back after the oxygenator into the jugular vein. And you can also see where the cannula is in this situation. The return cannula is from the jugular and into the KO-atrial junction, and the exit cannula is near the IVC atrial junction. And indications we talked about, cardiogenic shock is an indication for VA ECMO and cardiac arrest. We see that when patients are on prolonged cardiac arrest and on ACLS, we talk to the ECMO team to see whether they would be a candidate for ECMO. And one of the most important considerations is, do they have a reversible condition which could be reversed when the patient is on ECMO, so that they could recover meaningfully and if we can wean them off ECMO. That's the most important question all ECMO providers think before they offer ECMO to patients here. VV ECMO is using mainly for severe ARDS, and this was very commonly used in patients with COVID, and so that's a use for VV ECMO. Just from a logistics standpoint, we have approximately 3 ECMO devices in our hospital. They try to usually keep one for emergency situations, so 2 is being actively used, and they try to be judicious about it because we have just 3 for such a big hospital system. Contraindications, like we said, irreversible multi-organ failure. Usually the patient is not going to get any better with the ECMO, and it's not going to be a bridge to meaningful recovery. So most of them, they don't get offered ECMO. Severe aortic regurgitation, like I said again, if you're having VA ECMO and you're putting pressurized blood through your femoral artery, it's going to get back into your heart and going to fill up your heart and just going to cause increased strain with that. Intracranial hemorrhage, patients need anticoagulation with VA ECMO. It's not mandatory again with VA ECMO or VV ECMO. Most of the tubings these days are heparin bonded tubing, so we can get away without having the patient to be on anticoagulation if needed, but it's usually a good conversation to have before we decide ECMO and different ECMOs. Cannulation, just to give you an idea again, if you see the size of cannula is significantly bigger now, and the cannula size is usually dependent on patient's body surface area or weight. It helps us to see how much flow they need, and all we are trying to achieve with the size of cannula is trying to get laminar flow, because the more if we don't have laminar flow, it's going to cause more shear stress to your RBCs and just cause increased hemolysis. So that's why we look at cannula sizing, and the venous cannula, again, it's much bigger because it's not pressurized blood, it's more like a dependent flow, so we try to use a bigger cannula usually. Again, for VV ECMO, we have different kinds of double lumen cannulas where you don't need 2 separate cannulas. We'll talk about one in the next few slides. So a single cannula can be used in those situations. Surgical implications, again, anticoagulation. We can get away with anticoagulation for these patients if we need, and some patients develop like GI bleeding with ECMO, and they are taken off anticoagulation, and there are case reports which say that they do fine. And the other one is access line dislodging. Anytime you have a line, securing it is important, so it can easily get dislodged when we try to move patients from the bed to the operating room, from the operating table, or to the operating table, or from the operating table to the patient's bed when they move up to ICU. Some of the complications, bleeding again around the cannulation site, and intracranial bleeding because of the flow and other things, thrombosis, limb ischemia. Femoral cannulation sites, I think anytime you put a big cannula through your arterial site, the flow is mainly towards the femoral arteries, from the femoral arteries. So if the cannula is big and your femoral arteries are calcified or small or sclerotic, there is not enough flow to that leg, and so we need to keep a close eye on those situations. Things we can do is we can always place a peripheral perfusion cannula from the other side to make sure they have good flow distally. That's an option for patients who don't have good flow or have limb ischemia with the cannula in. Like Harlequin syndrome, it's specific to VA ECMO. Let me just go back to this picture so it's easier. So in these patients, if you see, the oxygenated blood comes from the femoral artery and goes towards the heart to perfuse rest of the body. This is in an ideal situation. When you look at the picture, it makes sense. But in patients who have some amount of cardiac output, there is still deoxygenated blood or blood coming from your heart, which is getting ejected. And now there's a competent flow from your heart and from the femoral cannula. And theoretically, at some point, the flow is not ideal. And so a Harlequin syndrome is where it's also called north-south syndrome, where the upper part of your body gets deoxygenated blood from the heart, and the rest of your body looks well perfused. So if you're looking at, your legs look really well perfused, but your hands or your other parts of your body above your head is not getting enough perfusion this is because the heart is still functioning and pumping out deoxygenated blood or not enough oxygenated blood to the rest of the body. The other thing with VV ECMO is recirculation. Again, going back to the picture to help us understand, your flow comes in from here and the flow exits here. So imagine there is just a continuous jet stream of blood coming from this cannula, like the distal cannula, into the proximal cannula, and there is almost like recirculation. There's not enough flow here. So repositioning a cannula is a good strategy in these situations to have good forward flow and make sure they have good oxygenation. VV ECMO is still heavily dependent on your left heart still functioning. So when a patient is on VV ECMO, they can still have heart failure and have low EF. And that's something to keep in mind when we are having patients on VV ECMO. VV ECMO is not a cardiac support device, I would say. It's more of an oxygenation device rather than something which augments or improves your cardiac output. Hemolysis, we talked about. Anytime you have shear forces on your RBCs, you have hemolysis, and most of the time it's with the RPM and the flow. There are different kinds of ECMO devices, but most of the flow devices we have now cost very low hemolysis, and that's why we're able to use it on a wide spectrum of patients. Infection, neurological injury, renal and hepatic dysfunction are other common complications with ECMO support devices. Going to the Impella family, I think this one was the most, has advanced over the last few years. There are different kinds of Impella. The 2.5 CP and 5.5 are left ventricular specific devices for patients who have low left ventricular ejection fractions or left ventricular cardiac output. So as the name suggests, they make things easier for us. The 2.5 gives you 2.5 liters of cardiac output, and the CP gives approximately 4. I don't know why they didn't name it 4. And the 5.5 gives approximately 5.5 liters of cardiac output. So overview, this is the whole the device, like the whole Impella device. So the blood comes in through here. There is an axial motor, and the blood goes out here. Okay, that's it. That's the whole device, and this is the driveline. So it's technically, most of the time, inserted through your artery, try to cross your aortic valve, and goes into the left ventricle. So positioning, again, is an important and a challenging part of these. And you have the inflow cannula here and the outflow cannula here. So we are not dependent on the LV anymore, or LV ejection anymore, for the cardiac output. So we talked about this. One of the differentiating factors for 2.5 and 5.5 we see is the 2.5 can be placed by interventional cardiology from a peripheral axis. So the cannula, it's much smaller in size, so it's easily placed. And the CP, again, can be peripherally placed using peripheral cannula. The 5.5, however, needs a bigger size cannula, and most of the time it's placed through an axillary cannulation. So you make a graft to your axillary artery and insert the Impella through the axillary artery, so that the patient has a better flow. And if you see, 5.5 to 6 liters is enough flow for a normal person to achieve like normal functioning. On the other hand, the 5.5 is also placed in the axillary artery. So most of these patients who have an Impella is in the upper part of your body, and these patients can walk and move around with an Impella device. So if a patient is on Impella like 2.5 for some time, you can switch them to 5.5, make them comfortable, and make them ambulate and get them back to functional status, and evaluate them for a more durable device like an LVAD in future. But with an Impella 2.5 or a CP, most of the time it's femoral cannulations, and you can't make them move because it's in the femoral artery. So those are some considerations we think about when we are choosing the different Impella devices we have. Indications, again, high-risk PCI. Anytime you have a high-risk PCI, there is many trials which say that placing a Impella device helps outcomes, reduces mortality, and also cardiogenic shock. Contraindications, if you have a thrombus, you can't put it in because you're going to shower clots everywhere. Mechanical aortic valve, because you're crossing with a rigid device, and a mechanical aortic valve, you're going to damage the valve and just cause more chances of thrombus down the line. Severe aortic regurgitation, again, if you don't have a competent aortic valve, the flow is going to come back. Cannulations, sorry, here you go. 2.5 is a 12 French sheet, CP is a 14 French, and if you see Impella 5.5, it's 21 French. So that's why we need a conduit or a graft through which we put the CP device in. Surgical implications, anticoagulation. So most of these devices have a purge system through which bicarb or heparin is injected through the device, so that the motor doesn't have clots forming in them. So that's something which is proprietary to these devices, and which can help them to be off anticoagulation for some time. So that's something to think about. And that's specific to cardiac surgery. Don't cross-clamp the aorta when you have a device running through it. It's not going to function really well and through that process. So this is the other side. If you're looking at the right-sided support and you need a device to support that, you have Impella RP, where the cannula is shaped in this specific way, where if you insert it through your femoral, it goes across and goes into your pulmonary arteries, so you can perfuse your pulmonary arteries. Again, this provides only support to your right heart, and your left heart is not supported in this scenario. Going through, just an idea, Impella RP is a 23 French sheet, and the same cannulation. It's more difficult to cannulate or put in an Impella RP just by how the catheter and the device looks, just makes it more challenging. Complications, again, vascular complications, hemolysis, again, it's like a much smaller motor, much smaller cannula, and much higher force, so chance of hemolysis is much higher. Device migration, most of these devices have a sensor these days where if it gets dislodged or moves, it can pick up an alarm, and so it helps us to understand that pump thrombosis, stroke, and infections, which is not specific to all devices. Protect Duo, this is the cannula I was talking about. More than a device, it's just a fancy cannula, I would say. So it's just a single cannulation site. You insert it through your jugular. It has this interesting curve where it picks up blood from your right atrium, pumps it into your pulmonary artery. And you can attach it to VV ECMO, so it's like two separate sites. And you're hoping your heart is still functioning, and it helps pump oxygenated blood to other parts of your heart. Contraindications, again, if you have tricuspid or pulmonary valve prosthesis, you can't cross any prosthetic valves with a stiff cannula. That's something to think about. And also, if the patient has severe pulmonary hypertension, you don't want to do that because it's forward flow, and if you have pulmonary hypertension, the device is not going to function through that. Again, cannula size, 29 to 31 French dual lumen cannula, much bigger than all the other cannulas which we have seen before. And surgical implications, it's in the neck, and it's a cannula which can easily get dislodged, so something to think about. And cannula migration and hemolysis are some of the complications which we would see. LVAD. So these are patients we see sometimes who are ambulatory and in like living a normal life, but have a circulatory support in them. So any of those common surgical pathologies these patients can have, and they come into our ED with those complications. So off my head, I could remember patients who had like a lap cholecystectomy with a HeartMate 3 device in, and we place PEG tubes and again trachs, expiratory laparotomies, appendicitis. All these patients can have any of those surgical pathologies. So to be specific, this is the device and just a magnified view of the device. This is the motor, and they have an internal magnetic ring. The actual flow or the propeller is magnetically levitated, so there is no contact device or a link which connects the propeller to anything else. So all these are done to reduce the chance of thrombosis and clots being moved from the LVAD to the other parts of the body. So the LVAD is technically connected to your left ventricle, and the outflow conduit is connected to your aorta. And from a surgery standpoint, the main things I see, which is important in these patients, is a drive wire, which gets tunneled under your skin, like it's subcutaneous. It doesn't go to your peritoneal cavity, it's under the skin, and has an exit site inside your abdomen, in your abdominal wall, probably on the right side, but some patients like it on the left side, or some surgeons do it on the left side. And they have an external system where they have a battery pack which runs the LVAD. So the main use is a long-term device. It can be used as a bridge to transplant to have very low EF, or it could also be a destination therapy, and that's how we do it also here. Contraindications, again, this is an isolated left ventricular, left-sided system with supposed left-sided function. So if you have RV dysfunction or any amount of RV dysfunction, even if it's mild, because of if you're having reduced left ventricular flow, once you start giving the normal cardiac output to these patients, they're having more blood flow into your right heart, and now they have right heart strain, which you have not picked up before. So that's something to look for. Even a mild amount of RV dysfunction should make you think multiple times before you place an LVAD. Active infection coagulopathy are again like contraindications. So you do it through a sternotomy or thoracotomy, and you're also looking at driveline exit sites. LVAD, just because LVAD and patients go out with LVAD and stay alive for a long period of time, we have significant data which says that they come back with multiple complications. So there are multiple case series which show that these patients can do well or survive technically without needing anticoagulation. Most of these patients need warfarin or aspirin. That's what FDA says. If you have an LVAD, you need to be on warfarin, and your INR should be somewhere between 2.5 and 3. So when patients start having complications from bleeding, they have tried to come down on anticoagulation. And when you have continuous bleeding, even with low anticoagulation, they take them off. And these patients have survived for 3 years. Like 15 patients on a series of 30 have survived 3 years with no anticoagulation. It may look small, but these patients don't make it long because of the LVAD. Avoid damaging the driveline during surgery and hemodynamic instability because of the pump or other concentrations. This is just a quick overview again of where the driveline is and how it's tunneled. It's not in the peritoneal cavity, but it's tunneling. So if by any chance it's tunneled in a wrong way, it can have an intraperitoneal component, and that's something to look for before we go into surgery. The easiest thing we can do is get an ultrasound. Most of these have metallic or silastic material, which is clearly visible on the ultrasound. So you just put your ultrasound on the skin, see where the drive wire is, and mark it preoperatively so that when you're going in for surgery, you know where the drive line is and you don't get to injure it. Driveline infections is the biggest limiting factor for LVAD because that's a common site of infection. If you have a driveline infection, you need to explant the whole device and put a new device in or create a new tract through which the driveline comes out. Pump thrombosis, GI bleeding. So GI bleeding is again a very common thing we get called about, or surgeons get called about for as a complication. Most of the time they have AV malformations because it's a continuous flow and not a pulsatile flow. And von Willebrand factor deficiency because of the shear forces through the patients has when they have this forward flow of blood. We'll go through an algorithm to see how common GI bleeding is managed. Risk of stroke, hemolysis, right heart failure, and pocket infections are other complications with LVAD. So if a patient has LVAD and they have GI bleeding, most of the time it's resuscitation, anticoagulation, and optimization. And if they are hemodynamically stable, then we try to hold off warfarin, hold antiplatelets, let products, take guided resuscitation. Then they get an EGD and or colonoscopy. Most of the time, it's like up to 60%, it's an upper GI source, and only 40% of the time, it's a lower GI source. So you look at you find the origin. Most of the time, it's being managed by endoscopy. So GI colleagues help us with this part. And if you see anywhere, there is no or minimal role for surgical interventions unless they are not able to find out a specific location where it bleeds, or they're not able to cauterize or get the bleeding under control with these patients. So there needs to be a lot of steps before a general surgeon needs to be called in, but that's something to keep in mind for GI bleeding in these patients. So this is just a quick summary of the different devices. I think we talked in detail about all these devices. I'm just going to skip over this. So some considerations. We talked about bleeding and anticoagulation and managing them. So most of the time, if it's an elective surgery, these patients definitely need to be bridged if they're on warfarin, specifically for LVADs. From warfarin, you switch them to heparin infusion, make sure they have good levels, and then take him up for surgery. And this should be a good discussion with everyone before we decide to hold anticoagulation during surgery. And most of the time, we don't need to hold anticoagulation. We just need to be very meticulous with our surgical practices if it's a low bleeding risk surgery. Anything else, we need to have a discussion to hold anticoagulation. Most of these patients are dependent on that device for their cardiac output. So if it's an intra-aortic balloon pump, now we are looking at, is the balloon pump enough to keep them supported during anesthesia and recovery? So do we need to move them up a level and see if they are a candidate for ECMO or an Impella to get them through the surgery? Device position, anytime you move patients, there's a chance of device position, like dislodgement. That's something to think about. Infection control, again, there's a high chance of infection in these patients. And always multidisciplinary coordination for these patients. So get the cardiac surgeon involved, get cardiology involved, perfusionist, anesthesia involvement is always mandatory for these patients. OR setup, again, we need to have a team huddle before we start the timeout. It's usually during the surgery. Before these patients, a team huddle, even before the start of the case, or even if the patient is in the operating room, is a good idea. And most of the time, we prefer to do this in a cardiac OR, not because it's on the other side, but it's a much bigger room. They have the pump in the room. They have all the connections for the pump. Like if the patient needs to be put on pump, these are some things to keep in mind. If your room can accommodate a pump, if it has all the connections for the pump, if the patient needs to be put on pump during the surgery. And backup, we always talk ECMO or the pump on standby, as much monitoring as possible for these patients, and always bleeding risk because of the anticoagulation, 1 Willebrand factor deficiency, and the coagulopathy, which these patients usually have. And one of the other general principles is any kind of surgery, try to prep them from your chin to all the way down to your knees so that you have enough cannulation sites as options if they need to go on bypass, and also always have a thoracotomy kit in the room if they need any kind of urgent interventions. So device protection, secure the line always. If you have drapes under the device, mark where the line goes or the devices go or the cannula is so that you don't accidentally dislodge it, and minimize manipulation and anticoagulation. Again, communication is key for these patients. Speak with anesthesia and perfusionists at all times to make sure you have safe surgical process. A first case scenario, you have a patient on LVAD, acute cholecystitis again, and their INR is 2.5, and they have right upper quadrant pain. So ideally, the question most of us think is the patient considered unstable and they're candidate for cholecystostomy tube? A patient on anticoagulation with the cholecystostomy tube, most of the time the cholecystostomy tube goes through the liver into your gallbladder so that it doesn't get dislodged or moved much. So none of the IR colleagues would want to do that when the patient is on full dose anticoagulation. And again, these patients always are expected to have a normal quality of life, even though they have a limitation with the LVAD. So if they are stable enough and you think they are a good candidate, you can take them up for surgery, understanding that just because a patient is on LVAD doesn't make them not a candidate for surgical process. So challenges, again, it's a non-pulsatile flow. So most of these patients, if you feel their pulse on LVAD, they don't have a pulse. It's a continuous flow. If the patient is talking and interacting with you normally, you can be sure that the patient is having good perfusion. So that's some time where you just feel for a pulse and everything is normal, it's totally fine. And they also have a higher bleeding risk. And again, like we discussed about multidisciplinary discussion, heparin bridging, reverse INR, and always protect your driveline, identify the driveline. Because if you're going to cut the driveline, it's going to stop functioning, and without the LVAD, the heart is not going to pump any forward flow. If you're doing an emergency laparotomy on VA ECMO, so again, you have the cannula in your groin, so therapeutic anticoagulation, that's something to think about. We talked about team huddle, secure your drapes, anticoagulation levels. ACTs usually between 160s and 180s. You can always speak with your perfusionist and the team to come down to normal level and try to get this procedure done and get them back, start them back on anticoagulation when it's appropriate. Flow, it's dynamic process. Anytime you go into induction, the flow changes. So someone needs to continually monitor the flow and make sure they have good output. And always having a TTE helps us to give a clear idea of how your right heart is functioning, how your left heart is functioning, whether the cannulas are in good position, and also check for your limb perfusion at all these times. Laparoscopic cholecystomy with the VV ECMO. Imagine a patient, these patients are ideally those one who need cholecystostomy tube, but if they are failing a cholecystostomy tube, like if they have gangrenous gallbladder, that's an indication for surgery because cholecystostomy tube is not going to take care of your gangrenous gallbladder. So again, positioning of your necklines, pneumoperitoneum. A patient on VV ECMO, like we said, doesn't have a cardiac, it's not supporting the cardiac output, it's supporting their oxygenation. So a pneumoperitoneum is going to change how things flow, and that's something to keep in mind because it's going to reduce your preload and speak with and coordinate your pneumoperitoneum. Go really slow. That's some key principles we always look at. Anticoagulation is the same as before, and postoperatively, we just continue to monitor them and see what we need to do. There is one of the other interesting things about VV ECMO, or for that matter, even VA ECMO, is these patients theoretically don't need to get intubated and oxygenated because they're getting oxygenation through their ECMO device. So they can just oxygenate as needed. And VV ECMO is also an option when you can't safely intubate a patient, like if they're having tracheal surgeries or if they have upper extremity, airway surgeries where you can't establish definitive airway. This is definitely an option to look at for VV ECMO. So key takeaways, early involvement of the whole team is important, OR setup, device-specific precautions, and always have an exit strategy in hand. So always open up, expose your possible cannulation sites, look at, keep an ECMO at standby, and also be perfusion ready at any time. And patients with low EF, you can always reach out to heart failure cardiology team or interventional cardiology team to see if they would be a candidate for any kind of support devices which would help us, which would support us during the surgical time. And you can always remove this device post-op if they are doing well with the surgical devices. That's it. And these are my references.